Thank you. And then moving to the next topic, which is intervention for gastroparesis. Intervention for gastroparesis by Dr. Adan. Yeah, thank you.
Thank you for the introduction, and thank you very much to the organizing committee for giving me the opportunity to speak to you today. So I'm going to be speaking about interventions in gastroparesis. Gastroparesis, simply defined, is the delayed gastric emptying in the absence of mechanical obstruction. And as we all know, manifests with several symptoms, including early satiety, bloating, abdominal pain, nausea, and vomiting. There are several physiologic mechanisms for gastroparesis. Dr. Camilleri is going to speak after me and will do a much better job of explaining it. But it's a complex physiology, which is a coordinated effort at the cellular level, which is regulated by the autonomic nervous system and GI hormones. There are several mechanisms for delays in gastric emptying, which include vagal nerve injury, which occurs in post-surgical gastroparesis, autonomic neuropathy, which occurs in diabetes, intraduodenal hypomotility, impaired fundic accommodation, and pylorospasm. Some of the evidence behind pyloric dysfunction was shown in 17 patients where they did full-thickness biopsies of the pylorus and antrum, and they found that there was a 2 times the number of loss of interstitial cells of Cajal and 3 times the amount of fibrosis in the pylorus compared to the antrum. So there are several different interventions for gastroparesis. They include Botox injection, transpyloric stent placement, per-oral pyloromyotomy, also known as GPOM, gastric stimulator, laparoscopic pyloroplasty. That's a laparoscope, not a pipette. And subtotal gastrectomy. Since I only have 15 minutes, I'm just going to discuss the first 3. So I thought I would do some market research. I wanted to understand what patients are thinking. So I went on Facebook, and there's a gastroparesis support group. To my astonishment, there are 23,630 members as of last week. It's a closed group. You actually have to fill out an application, which I did. I was candid and said that I was a physician that sees patients with gastroparesis, and they did let me in. And I found this recent post, which covers a lot of these interventions. So the first person says, I had Botox injections in October. That just wore off. I'm getting another injection. If it works, then my doctor is thinking GPOM surgery. Can I hear how this has helped others? Or if the gastric stimulator has helped? The next person says, I just had me second Botox, and the doctor wants to do GPOM on me as well. I'm going to do it because at this point, I'm willing to do anything. Hope it works out for you, heart emoji. What exactly is a GPOM? The next person says, the gastric pacemaker was a disaster for me. After Botox not working, my gastric consultant said the gastric poem that I can have at my hospital will not work for me. Did Botox work for you? What is the difference between GPOM and balloon dilation? So you can see that patients are thinking about these interventions. And there's a lot of information out there that comes from these type of support groups. We had one patient that came to see us from Oklahoma, and my nurse asked her, well, how did you come see us from Oklahoma? She's like, well, your direct phone number was on the Facebook support group. So when to consider interventions? So this should be done only in patients with medically refractory gastroparesis, which really is patients with ongoing symptoms despite dietary modification and maximal medical therapy. They really need to have a diagnosis of gastroparesis confirmed on a 4-hour gastric emptying study. Nausea and vomiting should be the predominant symptoms. It really should be avoided in patients with abdominal pain as the predominant symptom. Some of these patients will not have any or minimal nausea and vomiting. Really avoid it in patients with chronic daily narcotic use and uncontrolled psychiatric disorders. It's really important to differentiate from similar conditions like functional dyspepsia and other gastroparesis-like syndromes. So the first intervention I'll talk about is Botox injection. So Botox blocks the release of acetylcholine from causing a functional paralysis of the pylorus sphincter muscle. The outcomes from small, early open-label studies were promising. In 2002, there were 2 very small studies with 6 and 10 patients respectively that did show some improvement. Follow-up studies were done in 2007, 2008. These were randomized controlled trials that showed that Botox is actually no different than placebo. So my personal take is that really there's an issue of durability. This is absolutely not a long-term solution, and there's an impact of submucosal fibrosis, and I'll show you an example a little bit later, which can limit future therapy. And based on this, the guidelines state that intrapyloric injection of botulinum toxin is not recommended for patients with gastroparesis based on randomized controlled trials. It's a strong recommendation based on a strong level of evidence. So next we'll talk about transpyloric stent. So the primary mechanism is to reduce pylorospasm. There is limited data. It's based on a 3-patient case series and a retrospective study of 30 patients. So Moen Kashab's group, in the 30-patient series, they had a clinical response rate, which wasn't very clearly defined, of 75%. They did have a significant stent migration rate of 59%. So this does raise the question, is there a possible placebo effect like there is for Botox? So this is something that we incorporate into our algorithm. So we've placed stents in the past year or so. We had 11 patients who underwent transpyloric stenting. This is data that we're going to be presenting at DDW soon. We had a 91% clinical improvement rate. This was based on a greater than 5-point on a 10-point scale. They did have mean weight gain of 5.4 pounds. We did notice significant stent migration in 73% of patients, although without major complications. And the mean time to stent migration was 16.5 days. So one of the biggest issues with the stents is there's not really a great stent for this. The stents that are available for transpyloric stents, they're 8 centimeters long, 18 millimeters in diameter, which you think about for the pylorus is pretty long. A couple months ago, we started to receive a new product that's a 20 millimeter lumen opposing stent. We have seen significantly reduced stent migration, and the reason for that, I believe, is that this is a dumbbell shape. It really opposes the stomach and small bowel. It's only 10 millimeters in length, so this might be more of the ideal stent type for the situation. Patients who did have a good response, they underwent a subsequent pyloromyotomy, and they had a 70% response rate. So next, I'll be talking about POP, or G-POEM. So this involves a physical disruption of the pylorus sphincter to alleviate pyloric dysfunction and reduce pylorospasm. It's a minimally invasive procedure with a pretty good safety profile. The data is mostly based on small retrospective case series. However, there are prospective data that are now just emerging. So from the published data so far, like I said, the majority are retrospective, but the clinical success has been anywhere from 70 to 90%. The most recent prospective study that was published shows a 90% response rate at 3 months. You can see the one issue is the follow-up. For all these studies, the average follow-up is between 3 and 6 months. There was recently a paper published in the Annals of Surgery by the Cleveland Clinic Group. They had 100 patients that underwent this procedure over about an 18-month period. They had an overall improvement in the GCSI of from 3.8 to 2.5, which is pretty significant. And then the 78% actually had improvement in their overall gastric emptying studies, and 57% actually were able to normalize their gastric emptying studies. This is multi-center prospective data that is going to be presented at DDW in May. So this is a multi-center prospective study at 6 tertiary centers. This included 73 patients with refractory gastroparesis. The clinical success at 6 months was 58%, but you can see it considerably drops off at 12 months of only 37%. There was quality of life improvement in the subscales, and you can see when you look at the overall improvement in the GCSI, at the 3 months is kind of the sweet spot. 6 months you start to creep up a little bit, and then 12 months you have that drop off. Personally, I think the quality of life benefit is really the opportunity for this procedure. This was a recently published retrospective study of 30 patients. GPOM was associated with significant improved quality of life. This was based on the SF36 scores. At 1 month, 78%, and by 12 months, it was still at 70%, so this is pretty significant. What I tell my patients is that this is certainly not a cure. If we can improve your quality of life by 50%, I think this is a huge success, and a lot of this is help setting expectations, and this is where the quality of life can really come into play. They also looked at subjectively the gastric emptying studies. They had improved in 78% of patients and normalized in 48%. And very interestingly, they were able to significantly reduce their number of ER visits and hospitalizations. So prior to the procedure, they had 2.2 ER visits per month, and this decreased to 0.3. Hospitalizations went from 1.7 to 0.2, so pretty significant. They had 7 patients that they looked at historical controls, which really didn't have any difference. So this really goes to show that this can have a significant impact in the patient's quality of life. So it's really, really important to have multidisciplinary evaluation. This is how we do it at Northwestern. We have a motility specialist that ensures that patients have been maximized on medical therapy, and interventionalists like myself. They see a dietitian, and I think actually the most critical component is the involving a brain-gut psychologist. They're able to help manage, cope with chronic disease, and really help set expectations in their understanding, and this can really be beneficial. So Dr. Camilleri recently published this really elegant algorithm on the treatment of refractory gastroparesis. To some degree, it mimics what we do. However, we don't do the pyloric Botox, and I hope that Dr. Camilleri doesn't stab me on the way up to the podium next for desecrating this. But so instead of the Botox, we do the transpyloric stent, and we put it in for 4 weeks. We do EndoFlip. The data on EndoFlip is a little all over the place currently. There's a lot of work that's needed to standardize this. But we put this transpyloric stent in for 4 weeks, and the patients, pretty much right away are able to tell you if they have some sort of response. If they have a good response, then we'll go ahead and do a pyloric myotomy. If they don't have a good response, then we'll remove the stent, and then we'll just try and maximize their medical therapy. They may get a GJ tube or TPN. So this example, the most recent case I did, this was the patient's pylorus based on her index EGD. It's actually kind of narrowed. And just by passing the endoscope, there was actually a little disruption of the pylorus. This is after the transpyloric stent. I do suture these in place to help minimize migration. So this is the actual procedure. So she had post-surgical gastroparesis. So usually we start about 4 centimeters proximal to the pylorus. I make a little mark just to note the distal extent of where my incision is going to be, because I don't want to make the incision too long. And this knife does injection as well as incision. So we'll make the initial mucosal incision about 2 centimeters in length. We'll divide the submucosa in order to get the endoscope into the submucosal space. And then once the endoscope enters that submucosal space, you'll identify the submucosa, stains very nicely with the blue. You try to stay as low to the muscle as you can as possible to really avoid mucosal injury of the stomach. So in this case, I put just 1 milliliter of epinephrine into the 1 liter bag, and this helps create that pale view, and then you can kind of see where you're going. And I'm moving along thinking that this is going really nicely. However, I've gone way off course here. All the way around the pylorus, really have no idea where the pylorus is here. This is a different patient. You can see what the pyloric ring is supposed to look like. It's pretty obvious. When you inject it, you get that nice blue dye behind there. And then when you do the dissection, it's pretty clear that you're actually cutting the pyloric sphincter. And you make a little incision, and then you can see, okay, that's definitely the muscle, and then you can carry on. Going back to this patient, I honestly couldn't find the pyloric sphincter. kept looking. I said, well, maybe this is it, but there's a lot of weird muscle stuff going on here. There's a lot of fibrosis. Maybe this is it. Usually the duodenal submucosa kind of pushes away. It really wasn't here. So maybe this is it. And based on that little incision, it does look like this is actually the pyloric sphincter. And this is when you saw that very narrowed pylorus on the previous slide. And then you can carry on with the myotomy. I use an insulated tip knife. To me, I think this has a better safety profile that you can protect the duodenal mucosa behind there. And just since we're doing a pulling motion, this is ideal for this type of knife. And you really want to make sure that you get a full thickness myotomy. And as you're incising the pyloric sphincter, you can see the nice pink serosal layer behind there. And then with a couple of clips, it's closed. So in conclusion, interventions for gastroparesis can be effective in properly selected patients. POP has shown promise, but long-term outcomes are currently unknown. So for future directions, we really need to focus on patient selection, really need to identify those with pyloric dysfunction and pylorospasm. We are starting to enroll patients very soon in a randomized controlled trial of transpyloric stent versus sham to evaluate the stent as a predictor for future response to POP. And there is a randomized controlled trial that started in Europe, I believe, of POP to sham, and one that may start in the United States shortly. Thank you.